Okay, everybody. We're going to talk about drug administration here. And I always begin with this slide here because it kind of says it all. The only difference between a drug and a poison is the decimal point. So there is math involved here. You have to figure out how much of the drug you're going to give, because if you give too much, you can kill them. If you give them too little, you may not do enough good. So there are several videos on my YouTube channel which deal with drug calculations and general math. So revisit those if you're having trouble. We'll go over some of these in class, but you're going to be needing to come up to speed on that. So we're going to talk in this particular series of lectures, or in this one anyway, we're going to talk about the different routes of administration and the important things to deal with when talking about drug administration. So you notice that anything in red here is important. That means it will be on a test. Okay? So we want to make sure that these are the 7 rights of drug administration. We want to give the right drug in the right dose, in other words, the right amount, to the right patient via the right route. There are several different routes that we give medications, using the right technique and giving it the right time, which of course in the medical office is usually right then and there, but we may be instructing patients on the use of their home medications as well. And then providing the right documentation through the medication record. So we need to make sure we have the right patient, and we use two forms of patient identification. Have the patient say their full name. Don't ask them or don't say your name is Bill Smith, right? You ask them to spell their first and last name and give you their date of birth. If it's a patient in the hospital, you can use the ID band, but some of these have errors in them, so you need to still confirm their ID through the other means. The nice thing about barcode identification bands, when they're working, is that it correlates with what's in the computer system, so it will automatically track the drugs and say, no, you can't give this drug yet, or no, it has a problem with another drug. So those are very valuable parts of the ID band system. So make sure that you have the right patient's chart and that you've reviewed it ahead of time to know that you are in fact giving the drug that was ordered. And you know, giving a medication not indicated for that patient, it can be a very serious thing. It's also a violation of HIPAA. So make sure that you give the right medication to the right patient at the right time by the right route in the right dose. Okay. So here's how we do it. When we're giving the drug, we want to make sure it's the right drug. So the first thing we do is we look at the label. Is it the right drug? And we want to make sure that it's sealed and not tampered with. And this is called diversion of drugs, when somebody tampers with and removes a drug and replaces it with something which is non-pharmacological. We have to be very careful of this because employees have been known to steal drugs very creatively, so that unless you inspect the packaging really close, you wouldn't notice that it's happened. And I can give you instances of that in class later on. So we check the medication label at least 3 times. The more the merrier. You can't overcheck a label, but you can undercheck it. So we check it when we're taking it from the shelf. We check it as we're drawing up the medication into a syringe or the pills or whatever form we're giving it in. And then we check it just prior to giving to the patient. And then I would recommend a 4th time of checking it immediately following giving it to the patient. Okay? We want to know the name of the drug, the expiration date, and the concentration or the strength of the drug, because certain drugs come in different strengths. For example, heparin comes in several different strengths. And not too long ago, a couple of years ago anyway, I think something like 7 newborns died because they were given the wrong dose of heparin. The heparin bottles looked almost identical, but they were different concentrations and they were given too much, and these newborn infants died. So it is very important that you make sure that you've either got the right concentration or that you know how to dilute it down or average up so where you're giving the correct amount. Look at the vial of medication, and we're talking primarily with injectables here because they're the most dangerous drugs that we give. But we still have to look at oral medications, pills and tablets and capsules and things like that. But we want to check to make sure if it's a liquid, that it's clear, that there's no precipitate, or that it's cloudy. Now some things like insulin will be cloudy, and that's perfectly normal, but most drugs should be clear in their vial or ampule. If it's pills or capsules, they should be intact. And here's the thing, if you need to divide a tablet to give the correct amount, the only tablets we can divide are ones which are scored. They have a little groove down the middle of them that allows us to split that tablet into two parts. If we don't have a medication that allows us to do that, that means that we either need to round up or round down to the nearest whole tablet. So you need to get with the physician again and see exactly what he wants to do in that regard. But you can't divide unscored tablets. So we want to make sure that the medication is what was ordered. And if it's not the ordered strength, we need to do a calculation to figure out how much of it we will give based on what we do have. And that's not uncommon. You have one strength of a drug in your office, but the doctor orders another strength. You may have to modify your drug dosage to make sure that you're getting the correct amount. Okay, once again, recheck the patient orders, recalculate the dosage, and always check calculations with somebody else. Don't do it automatically and just say, I'm right. Go ahead and double check it with somebody else to make sure that you're getting the right amount. So here's that incident I was talking about where the babies died as a result of giving the wrong dose of heparin. Okay? Now, here are the two main routes. Now, there's plenty of other routes under these, but we talk about enteral routes, which are those that enter the body by the GI tract. So these would include oral, or PO, we swallow them. Buccal is absorbed in the cheek. Sublingual is absorbed under the tongue. Rectal is given in the rectum, suppositories. And then inhalation, it's absorbed through the lungs. Parenteral routes are those that are given by other means other than the GI tract. So these would include the injectables of intramuscular within a muscle, subcutaneous beneath the skin, and intradermal between the layers of the skin. Absorption, which includes intranasal in the nose, and then transdermal, which is through the skin. And something to keep in mind about transdermal medications is that if it absorbs through the patient's skin, it will absorb through your skin as well. So always make sure you're wearing gloves when you're handling transdermal medications. So enteral routes are generally slow and unpredictable. These are pills that the patient takes and it enters their GI tract. Now, buccal and sublingual are pretty rapid in absorption, but the PO routes, where we just simply swallow a pill, is very unpredictable in how it's going to work. It depends on what kind of drug is given. We have prodrugs, which are active drugs that when they are taken into the body, the liver will detoxify or take out about 90% of that drug from the circulation before it ever reaches the target organ to be processed. So when they are figuring out the desired or the correct dose to give a medication, when they're doing their clinical trials, they have to figure out how much the liver is going to degrade that drug before it ever makes it to the target tissue, because only 10% of the drug is actually going to get to the target tissue. We also have drugs which are given in an inactive form and activated by the liver. So they become active metabolites. That's actually what the prodrugs are. Most drugs are deactivated by the liver, but prodrugs are activated by the liver. So, of the enteral routes, buccal, sublingual are the most rapid. PO, swallowing a pill, not very good. Rectal are pretty rapid because you have a lot of good blood supply down there in the rectum. Now let's talk about parenteral routes. So these are faster routes because they bypass the liver. They don't have to go through that first pass metabolism through the liver. So when they're given, they immediately enter the bloodstream. I say immediately. If they're given IV, they immediately enter the bloodstream. We don't mess with IV ones. We stick with IM and sub-Q. IM, you give it in a muscle, and it takes 15 to 30 minutes to act. Subcutaneous usually takes about less than 15. Drugs that are given subcutaneous include insulin, and some of the other diabetic medications are given that way as well. The reason we don't mess with IV medications is because once you push them into the vein, they are active and they're working, and there's no way to suck them out. So if you make a mistake on an IV med, it can have serious consequences. So for that reason, MAs do not mess with IV medications. That's strictly a nurse that would deal with those. So the right time to give a medication in the doctor's office is when he tells you to, okay? Sometimes it's even more urgent than that if the patient's having an anaphylactic reaction. At other times, you just give it before the patient leaves, immunizations, for example. There are other times where you're going to be instructing the patient on how many times they are going to take their medication. Here are some of these abbreviations, and you notice they're in red, so you need to know them. QD means once daily. BID, bis and die, means twice daily. TID 3 times. QID 4 times. Q4 hours means every 4 hours, or Q4H means every 4 hours. Q8H means every 8 hours. Okay? So if I were instructing a patient and their prescription said give 1 tab BID, that would mean I'd give 1 tablet twice a day. Now, when we talk about technique, again, depending on whether we're giving an injection or we're giving an enteral route, we have very specific techniques, and we'll go over these in class as well. For example, IM injections are injected at a 90-degree angle to the skin, and the skin is pulled tight, whereas subcutaneous injections, the ones that go under the skin but not into the muscle, are given at a 45-degree angle, and the skin is pinched up to separate the subcutaneous tissue from the muscle. Okay, so IM 90 degrees, sub-Q is given at 45 degrees. Rectal suppositories are dependent on what age of person you're doing this to. 2 inches for an adult, half to 1 inch in children, no more than a ½ inch in infants. So rectal medications would include Tylenol, and the abbreviation for rectal is PR, per rectum. So if we were to give Tylenol PR, PRN for fever, to a child, we would say that's Tylenol per rectum as needed. PRN is as needed. And we, depending on the age of the child, would determine how far up we would insert the suppository. And the suppository should lie up against the rectal wall. So if the rectum is full of stool, you're going to want to angle that suppository so that it's up against the wall and not buried in the stool. Everything's a technique, right? And it's important to use sterile technique when you're drawing up and administering your medication. This is really easy to violate, and we'll play with this a lot to make sure that we get that down, so that it would be a shame to give your patient some form of injection and then have them develop an infection on top of it. The right documentation, and this is true for everything in medicine. If it wasn't written, it wasn't done. Keep in mind that if somebody decides to sue your doctor's office or you, it's not going to happen tomorrow or the next day. It's going to happen 2 years down the road. And consequently, you're not going to remember a thing unless you've written it down. So the more complete you are in the patient's chart and their MAR, the more, that's the medication administration record. So the more complete you are in the MAR, the easier it's going to be for you to recall that information later, and the easier it's going to be for people to figure out what you did. Okay? But if you didn't do it, it wasn't done. So we include the strength, or the name of the drug, the strength, and sometimes we include the manufacturer's label or lot number, the amount given, the route it was given. So if we gave it IM in the left deltoid, we would write IM left deltoid. And then we would add any patient side effects, patient monitored for 15 minutes, no adverse side effects. And then we would write our name with our signature, date it, time it. If it wasn't written, it wasn't done. So when we're giving a medication that is ordered by the doctor, we do have to consider what other medications the patient is on. Or what over-the-counter meds do they take? What herbal meds do they take? And here's a big word, contraindications. Do they have any condition that would make it unsafe to give that medication? That's what a contraindication is. It's against indications. Contra means against, so against indications. It's a reason we would not want to give the drug. Sometimes we have relative contraindications, which means, yeah, the drug has some side effects, but the benefits outweigh the risks. But in most cases, we don't give a drug if we find it's contraindicated in a patient. And we've talked about anaphylaxis before. That's the allergic reaction, and people can have an allergic reaction to any form of medication. And it may not be the medication itself, it may be the carriers that are in it that allow it to get to where it needs to get. So anytime we're putting something in somebody, remember, it's just short of a poison. So we want to make sure that we give the correct dose and the correct route and monitor them for any signs that they're having problems with it. Here are some things that can affect the absorption of medications. Age. The extreme young or the extreme elderly patients have trouble with medications. Not only in processing the meds, but also in elimination. They have immature livers, or in the case of elderly patients, their liver's kind of playing out. And the kidneys, which are responsible for eliminating wastes and drugs, are not functioning to their full potential. Sex, we know that women have a higher percentage of body fat. I'm not saying women are fat. I'm just saying that relative to men, they generally have a higher percentage of body fat. Therefore, fat-soluble medications are stored more readily in women than in men versus water-soluble medications. Interestingly enough, we give a lot of medications to patients who have chronic illnesses. But chronic illness will impair the body's ability to absorb and distribute those medications, particularly conditions that would leave a patient dehydrated, because the body relies on a good hydrated state to be able to move these drugs around throughout the body. Okay? So again, age, weight, sex, we've already talked about these. Here's pregnancy class. So class A and B drugs, all drugs that we give have a pregnancy rating on them. So class A and B drugs are safe to give. Class C drugs need a little more research. Class D drugs, they're possible that they could harm the fetus, so we need to be real careful with those. And class X drugs, we simply do not give to pregnant women. Interestingly enough, years and years ago, one of the primary drugs used to treat morning sickness in pregnant women was thalidomide. And it turns out it resulted in horrible, horrible birth defects. So now what was once given in pregnancy is now a class X drug for pregnant women because of the risk of birth defects. It was almost guaranteed. Breastfeeding, we want to know if this drug will express itself in the breast milk and be passed on to the infant. As we said, anybody who's got a chronic conditions, particularly liver and kidney, we may have to adjust the dosage. If the liver's not working properly, the drug may either be decreased or increased in concentration in the body. And especially if the kidneys aren't working, we don't eliminate the drug, and so it begins to collect and build up and have a more additive effect. When we are dealing with patients, particularly elderly patients, we have to look at some other things, which includes the cost of medications. Anybody on a fixed income may not be able to afford certain medications, so we may have to work with the physician to come up with alternatives, generics, or perhaps some other drug altogether, what's covered by their insurance. In addition to that, elderly patients, some intentionally, some not, and this is not true with just elderly patients, but we have this thing called polypharmacy, and there's kind of two definitions for polypharmacy. One of those definitions is that the patient gets the same drug from multiple different sources. And this is usually true of narcotics, where a patient is addicted to the drug, and so they go to several different pharmacies to try and get hold of that drug. Now, there's lots of check marks in place now to keep that from happening. All pharmacies are connected, all Walmart pharmacies are connected to one another, all CVS pharmacies are connected to each other, so that if a person goes to one, every other pharmacy knows it. Now, I'm not real sure if all pharmacies are connected together. I'm sure that's coming. But that's one definition of polypharmacy. The other is a patient takes a lot of drugs. And these are typically the elderly patients show up at the doctor's office with a grocery sack full of different medications that they take. And some of those drugs may interact with each other. So we have to go through that list, plug them into the computer, and see if it flags any of those drugs. Things that we want to ask the patient. What prescription medications do you take and why do you take them? Now, as you get further along in your career, you'll find out that you'll be starting to remember these most common medications, and you'll know that if a patient's on a diuretic, they have a tendency to hold water and maybe have a history of congestive heart failure, and that's why they're on the diuretic. It makes them pee excess water out. What non-prescription drugs and supplements are they on, and what you're taking them for. And these others are pretty self-explanatory. I'm looking for one that maybe I didn't put up there. But we do need to ask them about illicit drug use. We need to say, do you use any illicit drugs? Heroin? Do you use fentanyl? Do you use cocaine, methamphetamines? Because those are very important before we give a drug to know if the drug we give them is going to have a problem with those. So you just tell them, this is for your own safety. I need to know if you're taking any illicit drugs or you have any in your system right now so that I can make sure this drug isn't going to have a problem with it. So there are different forms of medications. Tablets and capsules and things like that are the ones that we typically give PO or under the tongue. You can give some of them, like nitroglycerin tablets, are given sublingually. But some tablets are buffered or enteric coated or timed release. Any tablets that are labeled time release or capsules cannot be broken. When you break them, you cause more of the drug to be released than it should be at any one time. And remember again, only scored tablets can be divided. If it's a solid tablet without a score, you can't divide it. You either have to go up and down on your dose. Now, having said all this, there are a lot of patients who can't swallow pills well, and we'll mix them in yogurt. Well, generally not yogurt because antibiotics react with yogurt a lot. So applesauce, for example. So we may take a pill that's not really meant to be crushed and put it in applesauce just to get it into the patient, knowing that, we have to get the doctor's permission to do that, but that may be the only way to get the medication down. Now, I like to concentrate on the drugs that we give that are solutions because I like to concentrate on drugs that are given by the parenteral route because they're the most dangerous. They require the most training. So that's what we're going to concentrate on in lab. But here's some other ones. But first, the definition. A drug is a solution, which means that we have a solid amount of drug that has been dissolved in a solvent or diluent to create a solution. And depending on the amount of solid that we have dissolved in the solvent is going to determine the concentration. The higher the amount of solute that we've added to the solution, the more concentrated the drug is going to be, and therefore less of the drug we're going to give. Whereas a A drug that has a lesser concentration will be more dilute. Okay, that is the concentration. The concentration is the amount of solid dissolved in the solvent. Now here are the oral forms that these take, and I'll let you read those on your own. Rectal medications, we can give stool softeners to help relieve constipation. And if the constipation gets really bad, bowel evacuants such as enemas. And some of those are probably, most of them are just saline enemas. If a person can't swallow oral medications, there's a lot of them that we can give rectally. These would be patients who are on ventilators and or heavily sedated and can't take oral medications, or infants and children who are not yet able to swallow pills. Now they're soft, usually dissolve at body temperature. And again, we've already talked about how far they should be inserted. And again, any medications that's given by the rectal route will have PR written in the orders, per rectum. There are vaginal medications, those for yeast, infections, and other situations that occur with female genitalia. Typically, these are applied at night with the patient laying down so that they don't ooze out and decrease their effectiveness. Once again, some other oral routes and then some more parenteral routes. So buccal is absorbed through the cheek. If a patient's having a heart attack and we want to give them aspirin, we cannot give this aspirin orally. We cannot have them swallow that aspirin. Swallowed aspirin in a heart attack is useless. We need to have them chew the aspirin up and have it absorbed in the cheek so that it'll have more of immediate effect. Okay? And we do that because aspirin is an antiplatelet, so it will keep clots from forming. It won't do anything about the clots that have already formed, which are causing the heart attack, but it will help reduce the severity of the heart attack. Sublingual, under the tongue, nitroglycerin is a prime example. Another drug we give for somebody having a heart attack. Nitroglycerin will work within 2 minutes of giving it in the case of somebody having a heart attack, but only if it's given sublingually. If they swallow it, it will have no effect whatsoever. Transdermal through the skin, always remember that transdermal medications will absorb into your skin unless you wear gloves and keep it off of you. Intranasal medications are like nasal sprays, given up the nose, Flonase for allergies, Narcan, which is now in nasal spray form, which is given a one-time spray up the nostril to help reverse narcotic overdoses. And these are fixing the Narcan for intranasal Narcan is getting ready to be an over-the-counter medication, I have a feeling. Now, when we're talking about parenteral medications, they will usually come in ampules, which are little sealed glass containers, one-time use. You break them open, you take the drug out, and then you throw it away. Vial, which may be reusable, may have several doses, so a lot of the standard yearly vaccines will come in the form of a vial so that they can draw repeated doses out of that. Sterile technique is imperative here so that you don't contaminate the drug. Pre-filled syringes, these are drugs that come pre-packaged. All you have to do is assemble them and you give the medication. So it comes already with a syringe, a needle, and it's ready to give. These are primarily emergency medications that you would find on a crash cart because we haven't got time to draw up the meds. So we just screw the plunger on the drug and give it. Auto-injectors such as epinephrine are used they're spring-loaded so that when you push them against the skin, they immediately inject their medication. This is a painful shot. That's a strong spring in there. So you want to make sure that when you're giving an auto-injector to somebody that you kind of hang on to them, make sure that they don't jump out from under the needle when you give it. Carpojex, we'll talk about those. These take little cartridges that fit into a holder and allow you to administer the meds. Primarily morphine, Dilaudid possibly, but these are kind of falling out of favor. They're just kind of cumbersome to operate, so we don't see a lot of them anymore. So I'm going to go over this later. I'm going to go over the procedures for drawing up these things a little bit later on in a different video. Let's talk about needle gauges and lengths. And this is in page 607 of Ken's. Now, I don't know if that's the 13th edition. I think I've gone and corrected this to be the 14th edition. Check it and see. So the larger the number, the smaller the needle. Okay? So a 27 gauge needle is about as small as you can get, whereas an 18 gauge needle is pretty good size. So we use different lengths of needle, different gauges of needles, depending on which kind of parenteral injection we're giving. Intradermal injections are within the layers of the skin. So this is a very small, very fine needle, 27 gauge, 3/8 of an inch, at a 15-degree angle to the skin. This is all really important. You'll be asked. You'll be tested on this. We only give very small amounts of the medication that way. Very small amounts. TB skin test is a prime example of one that we would give this way. Subcutaneous injections go between the skin and the muscle. Use a little larger gauge needle, a 25 gauge needle, which again is going to be a little bit bigger than a 27. Half-inch needle, 45-degree angle to the skin, and the skin is pinched up to pull it away from the muscle when we give this. Now, some needles are short enough that we can go at a 90-degree angle, but we're going to practice it at a 45-degree angle. And we can give up to 2 milliliters of medication by that way. The intramuscular route, again, these are much bigger needles than up here because these medications have to get into the system quick, and some of them are thick, and it may require a bigger needle to push the medication through. So these are 20 to 23 gauge needles. It's 1 to 3 inches long. It goes at a 90-degree angle to the skin. And instead of bunching up the skin like we do here, we pull the skin tight so that it adheres to the muscle and allows us to get deeper into the muscle. And we will talk about each of these places to give it. The deltoid, which is the shoulder muscle, the vastus lateralis, which is the lateral part of the thigh, which is the most common route that we give injections in children. The dorsogluteal and the ventrogluteal, this will be the one we'll talk about most. Dorsogluteal is not used as often because of the likelihood of hitting the sciatic nerve. We can give larger amounts here, up to 3 milliliters. So again, the intradermal Mantoux TB skin test is a prime example. There is a flu vaccine that you can give intradermally as well, and some allergy testing. Again, a short needle, less than a half an inch, 27 gauge, very, very fine. Skin is pulled tight. Needle is inserted 45-degree angle to the skin, and the medication is injected in slowly until you get a wheal, which is a little kind of a bubble underneath the skin. If you don't get the bubble, you've probably injected it too deep. We'll talk about TB man test or TB. You'll have to go through a certification process if you give TB skin tests. So we're going to save that for if that becomes part of your job description. Subcutaneous injections, insulin, epinephrine in an emergency, although we now give these intramuscular mainly, and then heparin is given that way as well. Epinephrine for anaphylaxis, again, these are both now given intramuscular because we need to get in a little quicker than subcutaneous. Insulin is given in units, not milliliters, so sometimes we have to do a conversion on that. If you have an insulin syringe, it's measured in units. If you have a tuberculin syringe, it's measured in milliliters. So you would have to figure out with your insulin how many units per milliliter you have to know how many milliliters to draw up to give the correct dose. and we'll talk about mixing different strengths of insulin in class. Intramusculars for larger doses of medications. Again, the deltoid, and again, deltoid sizes vary. You see elderly patients who are skin and bones don't have a lot of muscle mass there, and it wouldn't be very good to give them a shot there. The dorsogluteal, again, not recommended unless you have to give a Z-Track injection, which we'll talk about in class. You can read about it in your book. Ventrogluteal is the most common. It's more lateral in the hip. This one's more posterior, and the risk is that you'll hit the sciatic nerve and cause them a lot of pain. And then vastus lateralis, the lateral third of the thigh, which we'll demonstrate in class, is good for kids. Not too many adults get a vastus lateralis injection. Z-Track injections, these are, again, I'll show you a video in class that will demonstrate the Z-Track injection. I don't know too many medications that are given that way. Okay, so that's it for the background information, and in another video we'll come back and we'll demonstrate the actual techniques for administering these medications, drawing them up, and then another video for administering them. Okay, so hang in there, watch this one, redo the math videos if you haven't done those, because we're going to be doing some math. I'll see you later.